In this case, I'm going to talk about the trapped haptic in a premium Toric IOL delivery. As we can see, here is a case of dense cataract, as it's clear. I did the mark at 180 degrees. Then now intraoperative marking the cornea at 150 degrees, where the axis of the IOL should be aligned with intraoperatively. As we can see, the 180 degrees, the white arrow and the yellow arrow, which is the axis where the IOL marks should be aligned with. I started with 2 paracenteses and clear corneal incision at 180 degrees, then staining the anterior capsule using the trypan blue and wash out the trypan blue and injecting dispersive OVD in back fill technique, as we can see, then starting the capsular rixes, which should be ideal around 5.5 or less than 6 millimeter to provide overlapping through the optic edge of the IOL to secure the toric IOL inside the capsular bag. Then hydrodissection, hydrodelineation, as we can see, and viscodissection, then gentle rotation of the nucleus. Here is we can see the sharp pointed tip chopper, which I use to apply vertical chop technique in this bronze brown cataract. As we can see, I impale the phaco tip inside the nucleus just close to the center, then trying to chopping vertically. This is dense. You can see the rotation of the nucleus, which was very difficult to separate, and chopping this is dense cataract because of the dense posterior plate. As we can see, I'm trying again to separate, but also it is not complete separation. I did chopping, chop in all parts, as we can see, trying to weaken this dense nucleus as much as I can. Then I shift to blunt tip chopper to complete emulsification of this dense nucleus. As we can see, here is continue the vertical chop in all fragment of this dense nucleus. As we can see, hold and vertical chopping, trying to separate the nucleus in vertical way, as we can see, but as we can see, unfortunately, the separation is incomplete. Now I inject also dispersive OVD all the time of the surgery to protect the back of the cornea, as I need a high ultrasound energy to emulsify this dense cataract, which is a crucial thing to protect the cornea postoperatively. Now I did a complete chopping of this dense nucleus, trying to complete the separation. Here is the dispersive OVD. Then I switch to blunt tip chopper, as we can see, and continue emulsifying. This is dense cataract. As it's clear, here is the end of the emulsification of this dense nucleus. Then I go to bimanual irrigation aspiration to clean up the cortex. As we can see, here is the bimanual irrigation aspiration. Now I have clean capsular bag, and I injected cohesive OVD, preparing the capsular bag for the Toric IOL implantation. As the plunger entered the narrowing cartridge nozzle, progressive compression and shearing forces locked the trailing haptic within the delivery system, completely jamming the injector mechanism. The surgical dilemma now becomes critical. Destroying the custom toric lens may require explantation and increased intraocular manipulation and abandonment of the original astigmatic correction strategy. Rather than forcing the injector, a controlled microsurgical rescue strategy is initiated using the scissor, which was carefully used to cut the cartridge nozzle away from the trapped haptic. Once the nozzle is cut, the trapped haptic immediately releases safely and automatically, confirming that the obstruction originated from high mechanical compression within the narrow nozzle channel. The toric IOL remains structurally intact, no optic tear, no permanent haptic damage. The original premium lens is successfully preserved. The lens is then safely implanted into the capsular bag allowing continuation of the planned refractive strategy without the need for lens exchange or surgical abortion. This case highlights the importance of understanding the mechanical dynamics of the injector-related complications in premium cataract surgery. In a premium toric IOL surgery, preserving the original lens may preserve not only refractive accuracy but also intraoperative safety. Sometimes patience and precision are the most powerful surgical instruments in the operating room. And thank you for watching.